So is the FRAX valid? So this is the same data you saw in 2 slides ago, Annie Kung's data. So what I did then was Annie Kung has a mean weight and height in her group, and this was a group without risk factors. Okay, so this was their fracture risk. So when we use the FRAX, if we use the China database, we basically don't treat anybody because nobody's had any risk. If we use the Asian database, in fact, it seems to underrepresent the risk, and that the database which seems to approximate Annie Kung's data seems to be the Japanese database. Okay, so, but if you look here, what we consider as really red flag, need to treat type is far fewer than actually treating based on the threshold. Sometimes, if we look at it that way, it might think, and I mentioned earlier that one of our problems might be actually over-treatment. The people who shouldn't be treated are actually being treated, and those who should be treated aren't actually being treated. Okay? It's been around for a long time, and we're rich enough to afford it. Then if we just said, well, what if we throw in risk factors? Because those were without any risk factors. This is the data, again, from the Japan FRAX. Okay, so this is from Japan. And now what I did was I changed this to 48 kilograms, so 7 kilograms lighter, and actually it made no difference. So whether you took a light person or a heavier person, we seem to get the same number. If we add secondary osteoporosis, which was one of the buttons down there, we see that, oh, actually it didn't seem to make that much difference. And if we added parent fractured the hip, that seemed to change it quite a lot. Okay, so when we do that, and if you have a history, then a lot more people get treated. And this group, whether this group might be the group that fractures when they're osteopenic, are the group to treat. Okay, so the use of the FRAX, when you throw in the risk factors, is that you start to see, well, now when this patient is at -2 standard deviations and they're, the T-score is -2 or T-score is -1.5 and they're 80 years old, their risk is actually quite high, and it might be useful for you then to think about treating this group. Past fracture, this one, Keng Wang said, hey, don't show this. Okay, so let's think about past fracture, because we've said that we should treat everybody with a past fracture. Okay, but past fracture is one of the buttons in there. And when you put past fracture inside, you find that actually even those with past fractures in the younger age group might not be at that higher risk. So although we tell everybody, and I said 2009, we treat everybody according to the guidelines because we don't know how valid this is. But once we start to think about treating risk, then we might start to think actually younger individuals might not warrant treatment, but certainly older individuals at higher densities might warrant treatment. So that's the effects of risk factors. Okay, so we see now that the younger age group, they seem to be at lower risk. So people have said that, well, maybe we shouldn't be having a 20% across the board. John Kennis worked on this UK data, and he said, well, maybe when you're younger, we have a lower threshold, and then when you're older, we have a higher threshold, because when we do our calculations on economic and whatever, it's worthwhile to do it this way. Okay, so how does this work for Annie Kung's data? Actually, for Annie Kung's data, when you plug it in and you say, well, 7%, it turns out to be, we might as well just draw the line and then just do what we've been doing, because this is what seems to be. But when we plug in the FRAX data from China and all that, again, we shouldn't be treating anybody. Basically, we should be treating people when they're -4. If there are no other risk factors, that means the woman in the street, because all of these risk factors, in fact, the majority don't have risk factors. If you talk about how many % of the population are on steroids, how many % of the population have rheumatoid arthritis, it's not really the majority. So the majority actually won't have risk factors. Then we begin to think, oh, should we or shouldn't we treat them? Okay, so I put this out because the FRAX just came out. We mentioned it in the guidelines, but we don't quite know how to work it yet. So, but it's just interesting to think about it. What have we done for the guidelines? Well, we say we can't quantify it very well. So we hand wave and we say, well, if you have a fracture risk which is high, you should treat. If you have a past fracture, you should treat. If your bone density is lower, less than 2.5, you might consider treatment. If you're older, which is quite an important thing, you would tend to treat. And if you're younger, you might not really want to treat. If your risk for bone loss is high, you might want to treat. If your risk for falls is high, you might want to consider treatment, but probably want to treat the underlying causes of the falls. Okay, so now I'm going to choosing the drug. Now, we talked quite a bit about the anti-fracture efficacy, and we see that, well, the drugs, you know, they work on the various fractures, and so what has turned out is that there are certain drugs which seem to work mainly for vertebral, and then the rest of them work for vertebral and non-vertebral. Okay, so that's basically two categories. And in addition to that, people start talking about extra skeletal benefits. So it used to be that, people talked about hormone replacement therapy because you could perhaps reduce cardiovascular disease, and the same was with raloxifene and stuff like that. And I guess this one is not that important anymore. What's important is actually the adverse effects of the drugs, of which, things like bisphosphonates with reflux and strontium with diarrhea, and then whatever other things. Drug cost actually becomes important because, in fact, on top, we said that actually the drugs are pretty much the same. So then the cost of the drug becomes an important issue. And unfortunately, drugs which are very, very useful, like parathyroid hormone, cost the world. The convenience of administration is also quite important because a lot of times the older people on multiple drugs, so how easy it is to take the drug does count. And there are patient contraindications, so patients with reflux, etc., and so these are important to consider when you're deciding on your drug. But pretty much most of the drugs, in terms of how effective they are, they all work to some degree. Okay, so this is some interesting data, and not a lot of data like this available. So I pulled this out from the Swedish database, and this is a place in Sweden that there's only one emergency department, so everybody who had a fracture actually goes down there. And so this is and they were able to break down by age, and this is like 20,000 over fractures, so it's quite good data. And they were actually able to divide them. So this is the age, and these are the fractures. So if you look at it, this is from head to toe. I said head, spine, chest, and hip. So what we see from here, and of course this is 100%, but if you look at the actual incidence, this one actually goes up with time. So at 50 to 54, it's like that, and then when you get older, the number of fractures actually goes up exponentially. Okay, so this one is just by percentage. The numbers are far more when they're up here than down here. If you look at it, interestingly, you see that actually hip fractures rise up very markedly, and in fact all the lower extremities fractures seem to become very important. The data which kind of astounded me was the spine data, because most of the time we tell people, oh, in your 50s and 60s and towards the early 70s, we suddenly get a rise. Then I looked and I said, well, I guess these must be clinical fractures that end up in the emergency department, which isn't a lot. But we've actually made some recommendations on, well, these are the drugs and you should use it at this certain time of your age. Okay, so HRT, we kind of recommend it mainly for menopausal symptoms, and then after we want to get off it as quickly as possible. But in actual fact, it's a useful drug as a secondary effect on the bone. There's recent data with tibolone as well. It's also used as an alternative to HRT for reducing menopausal symptoms. But then, although it reduces fractures, you end up having a higher risk of stroke. So you tend to want to avoid it in the older people. And it's the same with raloxifene. Because of the worry about atrial fibrillation, stroke, and stuff like that, you also try not to use it in the older people. So these would be used earlier. And then the bisphosphonates and strontium, we kind of know that if we're interested in the non-vertebral fractures, when these things start to rise, this is when we start to treat people with bisphosphonates and strontium. Because teriparatide is so expensive, we tend to leave it for the older, more fractures type of individuals. Calcitonin is, I guess, it's not a very useful drug, so it kind of gets used here, and there isn't a lot of data with non-vertebral fractures. And calcium and vitamin D are put here, but basically everybody should be on anyway, in addition to these if they warrant treatment. So in conclusion, there are actually many drugs available for the treatment of osteoporosis. Most are effective at reducing vertebral fractures, but there are differences in efficacy against non-vertebral and hip fractures. Although there are limitations in treating patients based on BMD, actually BMD remains important in osteoporosis management. Siok B has talked about it, and I think we can't get away from the fact that most treatments were based on it. However, absolute fracture risk is being used for treatment decisions, but as I have kind of showed all the permutations and combinations, we have to do a lot more work to tailor this estimation to our country. And the considerations in the choice of osteoporosis drugs include anti-fracture efficacy, the drug profile in terms of what they can do, the side effects, the cost, the convenience, and patient factors. Thank you.